Welcome to the Memorizing Pharmacology podcast. I'm Tony Guerra, the pharmacist and author of the Memorizing Pharmacology book series, bringing you mnemonics, cases, and advice for succeeding in pharmacology. Sign up for the email list at memorizingpharm.com to get your free suffixes cheat sheet or find our mobile-friendly, self-paced online pharmacology review course at residency.teachable.com/p/mobile. Let's get started with the show. Hey, welcome to the Memorizing Pharmacology podcast. What we're going to do is do a case study, nursing care of the adult heart failure patient in a long-term care setting, LTC. And what we want to do is maybe not take a shortcut as much as see maybe how a pharmacist can see it sometimes, where they just look at the medication record and they're already looking at a couple of interactions that are common and of concern, and they lead you to the answer without necessarily having to do all of the stuff with the case, but we'll go through the whole thing just for the activity itself. So what we're going to do is we're going to try to provide care for an adult patient in long-term care with a history of heart failure. We're going to identify some common assessment findings, and we're going to talk about some common interventions as we go forth. So here's the patient. Hector Fernandez is a 62-year-old male patient who was recently admitted to a long-term care center for frequent falls. This video I'm not going to play because if YouTube hears the video or its AI hears the video, it'll shut this one down. But you can go to Chapter 6, 14 Module Learning Activities and play the video. But the big thing is that the patient didn't want the TED hose on there, and then there's some other pieces that we'll kind of go through now. All right, so here are some questions that kind of came from it. So what is the underlying pathophysiology behind heart failure? A, is it the heart muscle fibers shorten, resulting in decreased filling volume? B, the muscle fibers are overstretched or weakened, resulting in a decreased force of contraction and ejected volume. 3, the contractility of the heart increases. Or 4, the heart muscle has increased force of contraction due to overloading of the ventricles. So when you're talking about heart failure, you want to think about that word failure. And the word failure is really talking about how it's failing to do its job. And it's failing to do its job because those muscle fibers are stretched and weakened. So you have a decreased force of contraction and ejected volume. And the big thing is that if you're getting less volume, you're getting less oxygen, not only to the body, but to the heart itself, because the heart feeds itself through the coronary arteries. So we'll check that and we see that oops, I never pushed the button. Okay, so here we go. The muscle fibers are overstretched. Patient in heart failure has a reduced force of muscular contraction. Okay. Next question is, what do you expect to find on your assessment when the nurse states the resident has 2+ pitting edema? So is it that applied pressure leaves an indentation of 3 to 4 millimeters that rebounds in less than 15 seconds? Does applied pressure leave an indentation of 5 to 6 millimeters that takes up to 30 seconds to rebound? The patient has swelling around the nail beds. The resident's pulses must be found with a Doppler. Okay, so what we're really doing is what's the difference between 2+ and 3+ pitting edema? So the 2+ pitting edema would be when we apply the pressure, leave an indentation of 3 to 4 millimeters that rebounds in less than 15 seconds. The 5 to 6 millimeters with 30 seconds, that would have been 3+ pitting edema. As you recall, the reporting nurse had described that Hector refused to allow her to apply his TED hose this morning. Okay. And then the purpose of the TED hose is to increase arterial blood return to the heart. And so that's the thing that we really want to look at is it arterial or venous blood? So if we think about how blood comes back to the heart, arterial blood is ejected out very high pressure system. But when we talk about coming back, it's that the veins with their valves are just not doing it. They're not able to, the patient's not walking a ton, and it's just really difficult for that blood to fight gravity and go back up. So the TED hose are really to increase the ability of venous blood to come back. So we would call this false. Okay, check it and yes. All right. And then based on the report that was received, what are the priority focused assessments that you would do with Hector? Well, would we do abdominal, renal, and neurological assessments? Would we assess HEENT, head, eyes, ears, nose, throat? neurological and skin assessment, or cardiac, respiratory, and renal. Okay. And so because we have a patient that does have that heart failure background, we would definitely check the cardiac, respiratory, and renal assessment. Okay. All right, so let's proceed to the next slide. All right, so again, we've got kind of one of those videos. I'm not going to play it, but I'll play the answers to the next pieces. Okay. Hector reports that his heart skips a beat. Based on this statement, what do you expect to find in your assessment? Difficulty auscultating his heart tones, an irregular heartbeat, a bounding pulse, or a regular heartbeat. Okay. So the skips a beat would probably be that irregular heartbeat. That's indicative of heart rate abnormality. And so we would probably find some kind of abnormal heart rhythm as we palpate and auscultate. Okay. We decided to take Hector's vital signs and note the following results: blood pressure 158/100, heart rate of 58, respiratory rate of 18, temperature 37.5 Celsius, oxygen saturation 95%, and pain level of 0. Okay. The vital sign results or which of the vital sign results are priority concern for this patient? So again, we've got a cardiac patient, history of congestive heart failure. So we would expect that would it be the temperature, the oxygen saturation, the blood pressure, or the respiratory rate? Kind of gave it away, but the blood pressure would probably be the most significant with this particular patient. Okay. All right, so we complete the respiratory exam, and it's kind of cool here. You can have a listen to would you say those were crackles, diminished, clear, or wheezing? Okay. Think we would go with crackles. It was a little bit of sound in there. It certainly wasn't clear, but we didn't really hear wheezing in there. I know it's a little bit hard to hear, but you can play the video on the slide as well. Okay. What do crackles indicate about Hector's condition? Does Hector have increased fluid in his lungs? Does he require IV antibiotics for his lung infection? Does he have pneumonia? And does he have a cold? So those crackles are really just the difficulty of getting that air in with the fluid in the lungs. Okay. All right. Then the last one, after you hear the crackles in Hector's lungs, which of the following priority assessments will you perform? Will you assess mentation, strength, and motor responses? Will you assess the respiratory rate, oxygenation status, edema, current shortness of breath, signs of circulation? Assess capillary refill, heart tones, and signs of skin breakdown? Assess for signs of numbness and tingling and pedal pulses. Yeah, the respiratory rate, oxygenation status, edema, shortness of breath, signs of circulation, that would be right. Okay. All right, proceed to the next. Okay. You assess Hector's lower extremities, and you have to see it to find the following. And then how would you characterize Hector's edema? Would it be 1+, 2+, 3+, 4+? Again, this is a video, so if you didn't see it, unfortunately, I can't I can't really show you. All right, and we're gonna see 3+ pitting edema. So it was pretty deep, and didn't really hear anything about the time with it, but again, you kind of do your best with the picture. All right, based on the information collected in your assessment, you determine Hector's condition is improved, worsened, or remains unchanged. Okay, so because of what we've seen, we'd probably say that this condition has indeed worsened. Okay. All right. Having gathered your assessment information, you consult Hector's admitting orders. What order takes priority at this time? Is it the digoxin 0.25 milligrams PO daily, the daily weight, the furosemide 40 milligrams every 12 hours by mouth, or aspirin 81 milligrams by mouth daily? And so what we want to do is we're going to look at the orders here, and We see that we're admitted to a virtual skilled nursing facility, CBC, Chem 7, and every 3 months. Administer O2 via nasal cannula to maintain pulse oximetry, 95% or greater. Notify MD if O2 sat is less than 90% with oxygen. Cardiac diet, 2 grams sodium, low cholesterol, low fat. Weight on admission and weekly weights. Physical therapy consult. Now here are the medications. Aspirin, enteric-coated, 81 milligrams, 1 tab by mouth every day. Digoxin, 0.25 milligrams every day. Furosemide, 40 milligrams PO every 12 hours. Metoprolol, 12.5 milligrams by mouth every day. Lisinopril, 10 milligrams by mouth every day. Atorvastatin, 40 milligrams by mouth every day. Acetaminophen, 500 milligrams by mouth, 2 tabs every 4 hours for pain or fever as needed. TED hose on while awake. Elevate legs 3 times daily. And what we see here are some kind of classics. If I had seen an issue with the patient and some kind of cough, I would have immediately gone to lisinopril. If I had seen a diabetic patient, I would have worried about masking hypoglycemia. If I'd seen a patient with muscle pain, I would have gone to rhabdomyolysis with atorvastatin. But I see digoxin and furosemide, and immediately I'm thinking hypokalemia before I even kind of go through to the next piece. So let's go back to the learning activity. And let's say furosemide, 40 milligrams every 12 hours. But let's figure out how would I know that? Like, how would I know what these medications are for? So we've got digoxin, furosemide, metoprolol, lisinopril, atorvastatin. Where would I look? And what you want to look at here are the endings. The semide of furosemide, that's what lets you know that it's a loop diuretic. The alol of metoprolol, and you had to memorize that it was 2nd generation, so this is a selective beta blocker. The PRIL, or pril, of lisinopril, and the vastatin of atorvastatin. And again, you can find that sheet on the memorizingpharm.com webpage. If you sign up for the email list, I give you a big sheet like this, and I'll show you how it looks. So we see the semide part of the loop diuretic, and we see that the alol here in metoprolol, and that's a 2nd generation beta selective. And we see the pril in an ACE inhibitor. And then we see it's going to be down here, the vastatin of an HMG-CoA reductase inhibitor, which is also Lipitor, the atorvastatin here. And then I think the antiplatelet was the aspirin, and then the cardiac glycoside is digoxin. So using those endings makes it a lot easier to kind of understand, okay, I know what I'm dealing with the medications right away. You don't have to look anything up. It just you just see the endings. But again, when you're reading medications, you're probably going to want to read from right to left rather than left to right. Okay? So going back to this, I would say furosemide, that would be the big issue, because if furosemide is causing hypokalemia, that's a big deal when we see digoxin. Okay, so we'll proceed to the next. We're going to look at the lab results. Okay, and we see here, and we'll make this a bit bigger, that we have hemoglobin that is a little bit outside of range, a little bit low. We see hematocrit is a little bit low. Mean corpuscular volume, 74.2, just a little bit low, the red blood cells. And then this is the CBC with differentials. So we'll go down to the next part, which is the Chem 7. And then we see the BUN a little bit high at 30, creatinine a little bit high at 1.6. But our real concern here is this potassium, 3.3. That is under the 3.5 to 5.3 milliequivalents per liter. And so when we see hypokalemia, it's probably caused by the loop diuretic. And with digoxin, that's a real big concern. Okay. So after reviewing Hector's laboratory results, which is a priority concern, the creatinine, the potassium, the glucose, or the hemoglobin, definitely say the potassium. Okay. Hypokalemia is what we're worried about. Okay. Based on the laboratory results, you should notify the provider. Sure thing. Yep. So what we're looking at is what would have the greatest effect on the potassium and heart rate, okay? And that would be the furosemide, digoxin, and metoprolol, okay? So the abnormal potassium level and heart rate require that administration and modification at this time. Okay, you gather information to phone to Hector's provider regarding his current status. What information would be a priority to report? Okay, so would it be the current appetite and last bowel movement, oxygen level and pressure, hemoglobin level and increased fatigue, or the presence of crackles, increased edema, potassium level, and heart rate? I think by now we've kind of got that this is a cardiac deal. So presence of crackles, increasing edema, potassium level, and heart rate. This is worsening heart failure. Okay, so this is just asking how you think the scenario went, and then opportunity to give feedback. So the big thing I kind of wanted to kind of come back to was, if you knew the stems, you knew that digoxin was a cardiac glycoside, aspirin was a blood thinner, furosemide was a loop diuretic, metoprolol beta blocker, second generation, lisinopril ACE inhibitor, and atorvastatin lipid, or HMG-CoA reductase inhibitor. And the big thing is that if you know those, it makes it so much easier. And that's kind of where this whole memorizing pharmacology comes from. I understand many of your professors are going to tell you not to memorize things, but what we're really saying is there are things you need to memorize as a foundation, just like you have to know the alphabet to succeed in vocabulary. Or you have to know medical terminology really to do super well in pathophysiology and physiology and anatomy. And what we're trying to memorize is what's the medication for, and then as we kind of understand the systems, then when we talk about side effects and therapeutic effects, it really makes sense because you went through the whole process. So when you understand heart failure, and I guess I could have gone into, what causes that hypokalemia when we get into the nephron and those types of things, but maybe that's for a different lecture. Thanks for listening to the Memorizing Pharmacology podcast. You can find episodes, cheat sheets, and more at memorizingpharm.com. Again, you can sign up for the email list at memorizingpharm.com to get your free suffixes cheat sheet, or find our mobile-friendly, self-paced online pharmacology review course at residency.teachable.com/p/mobile. Thanks again for listening.